Hello, ladies and gentlemen. My name is Stefan Esper. I'm one of the cardiothoracic anesthesiologists at the University of Pittsburgh School of Medicine at the University of Pittsburgh Medical Center. And today I'm going to discuss with you one of the advanced topics in anesthesiology, the respiratory system, specifically topics within thoracic anesthesiology. I have no conflicts of interest to this lecture that are related to this lecture. These are my disclosures. Now, today we're going to discuss three cases, and I would like to demonstrate the primary issues in thoracic surgery. And as listed on the slide that's in front of you, we're going to discuss, first, an anterior mediastinal mass, how we take care of those individuals, as well as how to take care of a mediastinoscopy patient, or a patient who presents for a mediastinoscopy, rather, a pneumonectomy, and we're also going to go through some special cases as well. The first is the anterior mediastinal mass. So I'd like to begin with a very short and brief case presentation. This is a 36-year-old female. She's coming in for a biopsy of an anterior mediastinal mass. This is going to be a needle aspiration biopsy. This is a patient with Down syndrome, and she does have gastroesophageal reflux disease and asthma, or reactive airway disease. On her physical examination, she does have some expiratory wheezing. She has an FEV1 and a peak expiratory flow less than 50% predicted in the supine position, and the CT scan indicates that she has a 50% obstructed trachea. So let's look at the key points. So these are some questions to look at for this sort of patient. What else should we evaluate? How should we monitor this patient in the operating room? How will the induction of anesthesia be? Which sort of anesthesia will we use? Local anesthetic versus a monitored anesthetic care versus a general anesthetic. Will we extubate this patient at the end of the case? And I think it's vital to also discuss the fact that we should not ignore other disease processes that exist in these patients. Now, certainly, we won't specifically hit on gastroesophageal reflux disease, as I have mentioned, or Down syndrome and some of the other issues there, but I think it's a very important point to realize that we should not forget these other disease processes in these patients. If you're taking the oral boards, they will come up again, and we should not have some sort of tunnel vision with regard to this is an anterior mediastinal mass and I'm only thinking about thoracic issues. So again, don't ignore the other disease processes. So preoperatively, what would we like to ask the patient? First of all, we're going to do a history and physical examination, and we're going to make that a very focused history and physical examination. And this history and physical will involve, obviously, an airway examination. Certainly in a Down syndrome patient like this, you would expect there to be a very large tongue. The patient may also have atlantoaxial instability, and that exam could be performed by palpation, and perhaps the patient may exhibit some sort of pain, although that is also a radiographic examination, which we will not cover today. Furthermore, obviously, the airway is always of utmost importance in these patients. So too is the cardiac examination, and so too also is the respiratory examination, where we see wheezing, where we could see wheezing in this patient. But furthermore, it's also appropriate to observe a patient like this when we see a patient who does have an anterior mediastinal mass. This tracheal compression, they can be significantly difficult for the patient to deal with in terms of do they have orthopnea? Do they have dyspnea? What is their exercise tolerance? So, for example, our patient is rather unable to lie flat. Let's say she had an SpO2 pulse oximetry reading within 90%. And she's sitting in bed short of breath, rather not laying down in bed short of breath. That means that when she's supine and she's short of breath, this anterior mediastinal mass is compressing her airway. And she comes in somewhat short of breath in this way. And so this is something to also look at. Does she have dyspnea on exertion? What is her exercise tolerance? So even for regardless if it's a Down syndrome patient or not, they still can be active, but are they as active as they could be even without the anterior mediastinal mass? And so we ask them questions. Can they ascend 2 flights of stairs? What is their life like? What are their activities of daily living? Things like that. So assessing the patient, looking for orthopnea and dyspnea are especially significant in a patient who has an anterior mediastinal mass, because you're concerned about tracheal compression in these patients. And this will affect your anesthetic management, especially with regard to induction and maintenance of spontaneous ventilation in these patients. So, for example, we see in this figure that this is a very significant anterior mediastinal mass, which I'm pointing to right here, and this is the trachea, which is unfortunately deviated to the right. Furthermore, we also have a bone that's compressing the trachea in this picture over here and also over here. And then we have another radiograph from a composite CT that indicates that here is the trachea, and you see that this anterior mediastinal mass is compressing it, and the trachea is now deviated to the left. These are all separate patients in this case. So if the patient comes in with shortness of breath, this is specific to the thoracic differential in many cases. So that could be secondary to mass compression of the trachea, which you can look at with regard to palpation. You can also observe the patient lying in bed, as we previously discussed. If the mass is compressing the great vessels, then you would most likely be expecting to see something similar to superior vena cava syndrome, or someone who has a larger face, a beet red face, a jugular venous distension, so rather large veins, especially within the upper extremities. Because if it's compressing the superior vena cava, then you could have large hand veins because you do not have a drainage from the venous system into the superior vena cava. Furthermore, these patients may be exhibiting some sort of neurological symptoms secondary to mass compression of the aorta and possibly the innominate and carotid arteries, depending on where it is. And so this is something to also evaluate in the patient. Another issue that we've also seen in the patient that also it could be responsible for shortness of breath is asthma and chronic obstructive pulmonary disease, both of which are involved in the reactive airway disease category for these patients, and she certainly does qualify. In terms of that, when we evaluate asthma and chronic obstructive pulmonary disease, we ask certain questions such as how many times have you visited the hospital for an exacerbation of this? Have you ever had an intensive care unit admission for this? Do you use bronchodilators all the time? Are you on chronic steroids, or rather chronic inhaled steroids? Do you require the use of oxygen? These are some of the questions that we ask. Now, obviously, within an oral board examination, you're not going to ask the oral board examiner these questions, so you can say something like, assuming that the patient has wheezing right now secondary to their asthma, or given the fact they have wheezing, this may be secondary to their asthma, and in addition to asking them questions such as if they have been to an intensive care unit or do they use chronic bronchodilators, I would subsequently treat them with a duoneb, understanding that the risk would be tachycardia in this patient. Or that's a rather somewhat crude response to a question like that, but that could be a way to frame the question in and of itself. And finally, within this patient especially, don't forget an anterior mediastinal mass can be associated with myasthenia gravis. Myasthenia gravis, as I'm sure you are aware, is an autoimmune disease which the antibodies attack the postsynaptic neuromuscular junction, and this leads to significant weakness in a patient. Of course, within the confines of myasthenia gravis, you're always looking for whether or not the patient is taking pyridostigmine. How long have they been taking pyridostigmine, or how long has the diagnosis been? Do they take a dose of pyridostigmine greater than 750 milligrams per day? Also, other things we can ask, and does it involve the ocular muscles? Does it involve the accessory muscles of respiration? So don't forget myasthenia gravis as a possible cause of an anterior mediastinal mass. And here are the symptoms and signs. Syncope, again, compression of the great vessels. Orthopnea, compression of great vessels and the trachea. Dyspnea as well, stridor, jugular distension, and cyanosis, especially if there is a significant hypoventilation in these patients. And so what testing can we order in these cases? Obviously, we have determined, if we can go back to our case study, the patient has 50% compression of the trachea. And how was that found out? This can be found out specifically by a CT scan that I have just recently showed you. Also, a chest x-ray can also show some deviation. Furthermore, an echocardiogram may be able to show some distension, or rather some compression of the ascending aorta. or of the descending aorta, possibly of the pulmonary vessels, although it might be very unlikely. But basically what you'd look for in the echocardiogram would perhaps be some sort of regurgitant lesions in those cases, because certainly if the heart is pumping up against an obstruction, then the heart itself may have dilated over a significant amount of time. This would also help to evaluate the strength of the heart and how the heart actually functions. Pulmonary function tests are obviously very important in these patients to determine FEV1 and also the peak expiratory flow. And also angiograms are specifically useful for great vessel involvement, looking at the pulmonary vasculature as well as the aortic vasculature. So again, here is the tracheal compression. This is from a CT scan that we've taken from a patient and from the resource that is quoted below, and we see that the trachea is again deviated to the right. So this patient presents, and what is concerning about this patient? Well, first of all, the patient is dyspneic when she's flat, and there's 50% compression of the trachea, which means that this patient is at risk for airway collapse. And the patients who have a variable mass, which varies with respiration, they can sometimes be more susceptible to collapse as well, secondary to direct compression. So can we do anything preoperatively for these patients? Well, we can certainly suggest steroids, radiation, and chemotherapy. However, with regard to the biopsy, most times the surgical team would want to obtain a biopsy of the patient without alteration with regard to radiation and chemotherapy. Certainly steroids may in fact be useful, but a diagnosis might be urgent to determine treatment of the patient. So now let's move on to flow volume loops, and this results in the effects of positioning on the airway. Now, I said before, variable obstruction, the patient is at increased risk for airway collapse. And flow volume loops, frankly, are somewhat poor predictors with regard to patients and how they're going to do in terms of the operation in and of itself. They certainly may be beneficial in determining the effects of positioning the airway. For example, perhaps you can sit the patient up, and this would significantly relieve a great deal of pressure on the trachea. An increased mid-expiratory plateau, noted when the patient's position is changed from upright to supine, is certainly pathognomonic for a variable intrathoracic airway obstruction. And this would be an indicator of someone who is at increased risk, as I said before. I cannot stress enough that a variable obstruction means that you are most likely at increased risk for airway collapse. So here is a picture of a fixed airway obstruction. This example includes tracheal stenosis and a goiter that does not vary at all with regard to positioning. And you see here within the picture there is limitation to the expiration, and there's also limitation to the inspiration. And I apologize for the link coming up on the screen at that point. There's also the variable extrathoracic. This includes tracheomalacia and vocal cord paralysis. And what happens when you, if we continue to the next, we see that expiration appears to be appropriate, but inspiration appears to be somewhat limited. And let's go back to this one picture that we have here. In that expiration, whenever you expire, the airways, in fact, are pushed out, for lack of a better term. They expand. And in inspiration, with spontaneous ventilation, the actual entrainment of air causes collapse of the airway, and this again occurs in tracheomalacia and vocal cord paralysis, and this would occur outside of the thoracic cavity. If we move on to variable intrathoracic obstruction, then we see tracheomalacia of the inner airways, and we also see tumors as well. This would mean that upon expiration there would be obstruction, and upon inspiration there would be expansion, and the curve would look like this. As you see, at expiration there's limitation to flow, but on inspiration everything appears to be normal in these patients. While they are poor predictors, and while you may receive this question on the oral boards, in fact, you may actually be asked to draw these curves on the oral boards, or at the very least, maybe you may be asked to identify these flow volume loops for the oral boards. So intraoperatively, what are the goals for these individuals? for any individual undergoing a anterior mediastinal mass procedure, whether it's going to be a needle aspiration or whether it's going to be resection, maintenance of spontaneous ventilation would be the most appropriate answer to these questions. Certainly, if you're going to do something like a needle aspiration, doing it under a local anesthetic with the patient supine while cooperating would be appropriate. You would not have to use a significant amount of anesthesia for the patient, as local anesthetic would be applied. However, for the use of general anesthesia, the tenets of this would be to maintain spontaneous ventilation, to use a bronchoscope to advance the tube, especially in intrathoracic airway obstruction when tumor may have invaded into the trachea. You would not want to damage that mass with the use of just the blind intubation, rather not a blind intubation using a laryngoscope, obviously, but advancing the tube without the guidance of a bronchoscope. And furthermore, in order to maintain spontaneous ventilation, you would not want to use a significant amount of muscle relaxation for these patients while you're doing the induction of anesthesia. So an awake fiber optic generally would be the appropriate choice, especially if you're going to do a general anesthetic for patients who are cooperative. In this case, the Down syndrome patient would not necessarily be cooperative for this case. And in that case, especially if the oral board examiners or in real life, if the patient is not allowed to proceed with an awake fiber optic, in that the patient is not cooperative, and in fact it would be safer to have the patient asleep while spontaneously ventilating to establish endotracheal intubation, then an awake fiber optic would not necessarily be the greatest choice. In fact, it would be rather a poor choice, especially if they're not cooperative. So to maintain spontaneous ventilation, I believe we'll get to that a little bit later, using generally sevoflurane as an inhalation induction, or sometimes individuals use ketamine. In any event, if you do end up doing some sort of a rapid sequence induction, there may possibly be a difficult ventilation or a difficult intubation. Needless to say, regardless if you're doing an awake fiber optic intubation or an asleep fiber optic intubation with a combined technique, we should have the difficult airway equipment in the operating room. The surgical team should be ready to do a tracheostomy and should be ready for a rigid bronchoscopy, which should be in the room. A gent ventilator should also be in the operating room, and the patient, this should be made a determination beforehand, whether or not this mass is so serious that the patient requires cannulation for ECMO prior to induction, or whether or not or to have the cardiothoracic surgeons on standby to place the patient on ECMO. And these are all very important things to remember in the operating room. Certainly for our case, the patient who has Down syndrome, who most likely will not be cooperative, it still is important to maintain spontaneous ventilation, and that could be accomplished with titrated doses of sevoflurane or the use of ketamine with an antisyllagogue such as glycopyrrolate. And a combined technique would be something that I would suggest with regard to laryngoscopy, which would sweep the tongue out of the way, and then the subsequent fiber optic scope, which can then be used to pass the endotracheal tube through the trachea while guiding it so that it does not harm the trachea or a mass that could be inside the trachea at that time. Postoperatively, these patients we should make sure that they experience spontaneous ventilation. The patient should be in the upright position, sitting up, and if there was muscle relaxation, administered during the maintenance of anesthesia, which generally, for this needle aspiration, if they're not necessarily require anything else other than standard ASA monitors, but if there was a more significant resection, certainly an arterial line as well as a central venous line should be placed. In addition, if the mass is obstructing the superior vena cava, as is evident in thoracic outlet syndrome, then there would be no blood flow generally coming back, rather minimal venous return coming back from the upper extremities and the neck and head into the superior vena cava. So in these cases, it would necessitate the placement of a central line where it has access to the inferior vena cava to drain into the right ventricle. So maintenance of these patients involves generally a volatile anesthetic, monitoring would involve with a rather invasive lines include an arterial line and a central line. Whether it's in the jugular, subclavian, or femoral depends on if the mass is obstructing or if the rib is obstructing one of the great vessels. Not great vessels, rather, if it's obstructing the superior vena cava. If you're extubating this patient, especially after needle biopsy when the anterior mediastinal mass is still there, they must be sitting up. They should be following commands, and I would not recommend doing a deep extubation on these patients because they could significantly lose their airway, and then you would be unable to ventilate and possibly unable to intubate at that time. Now, briefly touching upon the thoracic outlet syndrome and superior vena cava syndrome, again, if there is a compression of the superior vena cava, while the invasive monitoring would not change, and this could be with either an anterior mediastinal mass, which would go with the tenants that of which we just spoke, or thoracic outlet syndrome, which is a compression of the rib on the superior vena cava and the vessels. If there is an issue with that, then again, have to understand whether or not the mass is obstructing the vena cava and is obstructing drainage from the upper extremities in the neck. Again, if it is, then a central venous catheter or IV should be established in the lower extremities. If the patient is presenting for a mediastinoscopy, and this is generally done when patients have some sort of a tumor that they're looking to see whether or not it has spread to the mediastinum, or if an anterior mediastinal mass is large and they want to continue to take some sort of biopsies with a mediastinoscope. Certainly 2 large bore IVs, possibly even a central line for those larger cases, and also an arterial line. Now, there is some debate as to whether the arterial line should go on the right-hand side or the left-hand side. And the reason why is because if you place the arterial line on the right-hand side, this would give you better understanding of whether or not, during the mediastinoscopy portion of the procedure, the surgical team is compressing the right innominate artery. However, it will not, if they are compressing the artery, well, and they continue to say, I have to remain on the artery, I have to remain on the artery, and they're not coming off the artery, this will not necessarily give you completely accurate blood pressures, and you may be inaccurate. So in some cases, it may be better to put an arterial line on the left and a pulse oximeter on the right, because the pulse oximeter, especially if it has a good waveform with regard to the pulse, it may actually even show right innominate artery compression, and as we know, the right innominate gives rise to the right carotid artery and the right subclavian artery. Needless to say, if the arterial line or the pulse ox are dampened, then we would ask the surgical team to please remove the mediastinoscope from compressing the from compressing the right innominate artery. We would not want the patient to have a stroke secondary to lack of perfusion. Although this would generally not occur because they would most likely have some sort of collateral circulation through the circle of Willis from the left carotid artery, but that's for a different discussion. The main point is to say good access, blood on hold, okay, because one of the complications of a mediastinoscopy is they might sample the aorta instead of a lymph node. The aorta may look like a lymph node, or they might do it by accident. So blood on hold, and additionally, it's good to have either a pulse oximeter or an arterial line on the right-hand side. Again, this is just sort of a review of what we just discussed. Make sure that the blood is on hold because the aorta may in fact be injured in these cases. Now, we're going to leave this and we're going to go to single lung ventilation. So why do we do single lung ventilation? Well, there are multiple reasons, and they're labeled here. Surgery, if the patient is having a pneumonectomy or a lobectomy, perhaps even a larger wedge resection. If the patient has a bronchopleural fistula and we need to have that close, the patient requires closure of that without positive pressure ventilation. Infection, when we do not want infection to spread from one lung to the other, and also pulmonary hemorrhage. If there's hemorrhaging in the right or left lung, we would want to isolate those lungs. And so how do we do it? Well, the most common way is with a double lumen tube. And there are 2 sorts, a right and a left. The left-sided double lumen tube has 2 lumens, as does the right side. The left-sided bronchial lumen would, the reason why it is left-sided is because the bronchial lumen would extend into the left main stem while the tracheal lumen would ventilate the right. The right-sided double lumen tube would mean that the bronchial lumen extends into the right main stem bronchus, and the tracheal lumen would ventilate the left. There's obviously a double hookup that you can see at the top if I can just point it out to you. At the top here, there is a hookup that involves a special connector that can hook up to the ventilator, and then at the time of single lung ventilation, we would want to clamp one of the ports depending on which lung you're trying to isolate. It should be noted at this time that you should not clamp here. This does not allow the patient to extubate. In the connector, while it connects to here, then it has two connectors that come into one single port, and you should clamp one of those connectors that ventilate the lung. The most important issue with regard to the right and left, the differences, involve the fact that the left, because of the takeoff of the left upper and lower lobe, the bronchial lumen only has to have one orifice through which air or oxygen can be administered to the patient. However, in the right-sided double lumen tube, it has two orifices. You know what? I'm not actually sure how to pronounce that. I apologize for that, and no one's giving me any help back here. I don't know whether or not to re-record that, but I guess we'll just continue. Mistakes are made in multiple settings. So, and plus we need a little bit of humor in these sort of lectures because they become somewhat monotonous. I try not to have a monotonous voice. I don't know if any of you are familiar with some of the football films that are narrated by an individual, John Facenda. They're very, very good. I would actually narrate them right now, but I can't, I'm sure, because there's some sort of copyright laws. In any event, the right-sided double lumen tube, the Murphy's eye, which is used for positioning the upper, basically there is a Murphy's eye. There are two slots there for air to be administered to the patient, or oxygen, and one orifice actually is placed at the right upper lobe because the takeoff of the right main stem is somewhat, rather the take-up of the right upper lobe is rather high. So if the double lumen tube were to be advanced completely within the right main stem, we would not be ventilating the right upper lobe. So it does involve a little bit more difficult positioning. As we see here, you'd have to make sure that this orifice was facing the right upper lobe while this was ventilating the lower. And this does have a chance of being malpositioned either at the beginning of the case. It also has the chance of coming back up into the carina and then completely blocking off ventilation, especially if you're clamped on the right-hand side. It may completely block a ventilation. Also, the way we can do separation is with regard to a bronchial blocker, and the way that this is placed, this connection here goes to the endotracheal tube. This has the blocker going through it. This connection here has the bronchoscope, and this one is attached to the circuit. And the way that we would position the bronchial blocker is we would attach there is a loop here at the end. There's a loop at the end which is placed around the bronchoscope, and then we would use the bronchoscope to slide through the loop, go into the appropriate lumen, go into the appropriate main stem, and then we would advance the bronchial blocker over the bronchoscope, as is seen here, through, check the position, inflate the endotracheal tube cuff, and inflate that cuff and make sure that it's in the appropriate place. So how do we achieve isolation? As I said before, we would clamp one of the lumens of the double lumen tube. If we're using a bronchial blocker in order to achieve isolation, we would initially ventilate double lung ventilation with 100% oxygen. And then we would induce apnea. This is what I would generally recommend. After 2 minutes of apnea, then I would subsequently inflate the cuff of the bronchial blocker. And then this would actually, the reason why we ventilate with 100% oxygen for 2 minutes before inducing apnea, or rather we ventilate with 100% oxygen before inducing apnea, the reason why we do that is to create atelectasis, because oxygen easily diffuses out of the alveoli, and it creates atelectasis, and it also helps to facilitate isolation of the lung. Nitrogen does not diffuse very well, and the lung may continue to remain expanded for the case. So to achieve appropriate isolation, induce apnea, inflate the cuff, and promote atelectasis in that fashion. So now that we have talked about single lung ventilation, let's move on to a pneumonectomy or other segmental remover, and this leads us to our second case, which is a 68-year-old male coming in for small cell carcinoma. He's coming in for left pneumonectomy. He does have dyspnea on exertion, 2 liters of supplemental oxygen at home. He has digital clubbing and wheezing. His saturation is 90%. His hematocrit is 60, and his medications include albuterol, Advair, and oxygen. This is a case that is rich in questions that can be asked. So preoperatively, what should we do? Well, in addition to doing a significant examination, history and physical, as we discussed before, which involves definitely listening to the lungs and also listening to the heart to see if there's any sort of murmur, and also another airway examination. Furthermore, we should also do a CT scan, and we also saw the digital clubbing for this patient and wheezing, which indicate that the patient has been hypoxic for a specific period of time, especially if he has a hematocrit of 60 and a saturation of 90%. This could lead the reader or the examinee or the individual taking care of the patient to believe that the patient is generally hypoxic or hypoxemic. Preoperatively, in addition to the H&P, we should also look at a CT scan and a chest x-ray to see if there is any sort of mass effect. Evaluate the patient for chronic obstructive pulmonary disease because they may have a smoking history. And again, ask questions, are you on round-the-clock bronchodilators? And we may want to optimize, quote-unquote, optimize that portion for patients so that they breathe better. An echocardiogram for pulmonary hypertension is absolutely appropriate in these patients because if they're hypoxic, most likely they will have some element of pulmonary hypertension. They may even have right ventricular hypertrophy, possible dilation, and they may be on the brink of right heart failure. And so it would be definitely necessary to look at that. Labs for possible electrolyte disturbance, especially with regard to small cell cancer, we would be looking at sodium secondary to ADH secretion in these patients. So specific tests that we can get, and this is one of the most important parts of the lecture: pulmonary function tests, diffusion of carbon monoxide, arterial blood gases, the VO2, which is the consumption of oxygen, and the also stair climbing as well. And we have the 6-minute walk test, and then we also have the exercise SpO2, which can also be used in these patients. Now, pulmonary function testing. Just as a very good review here, and rather brief, I might add, in the green that we see in this picture, this is normal. The green would indicate that this patient, this is normal, so there's good expiration and good inspiration. Red indicates emphysema. Emphysema, and in this case bronchitis, here, which is indicated in blue, these are generally obstructive diseases, where there generally isn't too significant of a problem with inspiration, but certainly there is a significant problem with expiration. You can see the scooped out curve in the expiratory limb. Chest wall disease and pulmonary fibrosis, these are actually restrictive diseases as well. And so in these cases, you can have, especially in the purple, which is chest wall disease, you can't move your chest wall as well. While the entire curve may be proportional, so your FEV1 and your FVC, that ratio may be 1. Certainly, it can also be greater than 1, especially as you can see here in the pulmonary fibrosis category. Generally, with obstructive disease, that you would expect the FEV1 to FVC ratio to be lower or less than 1, and the less than 1, which would indicate some sort of obstructive disease. So, one of the issues to discuss here is predicted postoperative FEV1, and there are 42 total subsegments. On the right, 6, 4, and 12 in the right upper, middle, and lower lobe, respectively. And on the left, in the upper and lower lobe, there are 10 segments each. And here's the equation. But I'd like to do an example, if that's okay with you. So what it does, and I'll just briefly go over the equation, your predicted postoperative FEV1 is equal to the pre-operative FEV1 times 1 minus, in parentheses, the percent perfusion of the lung to be resected over 100 times the number of the segments in the lung to be resected over the number of segments in the lung. or more aptly put, and probably more simplified, if you're doing a pneumonectomy. Let's say you're doing a left-sided pneumonectomy, and the FEV1 is 100%. If you're doing a left-sided pneumonectomy, and you're going to take out 20 segments, and so on the right you see you're going to be taking out a left-sided pneumonectomy, taking out 20 segments. That means that 22 segments are left. 22 divided by 42 is equal to approximately 50% lung tissue in the left. 50% FEV1, which is the postoperative predicted, 50% FEV1 times the preoperative FEV1, which was 100%, is equal to the predicted postoperative FEV1. Now, of course, when they talk about percent perfusion, sometimes, in some cases, the lung parenchyma is so damaged that those tissues aren't perfused at all in any event, and resultantly, it will not necessarily significantly matter. But in this case, 20 segments, so if you assume 100% perfusion, everything is going very well, you take out the entire left lung, there are 22 segments left, 22 over 42 is how much you have left. There's approximately 50% of lung tissue left. 50% times preoperative FEV1 is equal to predictive postoperative FEV1. So that leaves 50% is the predictive postoperative FEV1. If the pre-op FEV1 were 50% and we were doing a left pneumonectomy, again, 20 segments gone, 22 segments left, nearly 50% of the lung parenchyma is left. So 50% times the preoperative FEV1, which is 50%, is equal to 25% predictive postoperative FEV1, assuming the perfusion is 100%. So there's obviously a huge difference between whether or not this patient is high or low risk for the pneumonectomy. And here are the guidelines. If the predicted postoperative FEV1 is greater than 40%, the patient should be extubated in the operating room. Between 20 and 40, evaluate for extubation. Generally between 20 and 30, they say consider extubation if all aspects are favorable with thoracic epidural. Other patients you can have a stage wean of ventilation. Between 40 and 30, if everything else is appropriate, including blood gas, over 60, depending if there's no AA gradient that's significant for the patient, or the CO2 is less than 50, extubate in the operating room. If the predicted postoperative FEV1 is less than 20, it represents an unacceptably high risk. Do not proceed. And this works the same for predictive postoperative diffusion of carbon monoxide. Now, other PFTs include forced vital capacity. High risk, if it's less than 50% or less than 1 cc per kilogram, it's high risk. Maximum voluntary ventilation is high risk if it's less than 50% of predicted or less than 50 liters per minute. Residual volume and total lung capacity, high risk if it's greater than 50%. And remember, those patients who have COPD, their total lung capacity increases. Cardiopulmonary reserve, another very important test. The maximum oxygen consumption, which is the VO2 max, if it's greater than 15 cc's per kilogram per minute, low risk. If it's less than 10, it is an absolute contraindication for surgery. The patient may never get extubated, and they may never get off the ventilator. Cardiopulmonary reserve with regard to the stair climb, if 5 flights, if your oxygen consumption is greater than 20 cc's per kilogram, low risk. If it's less than 2 flights, high risk. Decrease of greater than 4% while you're exercising, increased risk. 6-minute walk test. If you can walk less than 2,000 feet, that equates with a VO2 max of less than 15 cc's per kilogram per minute. And that would be a high risk patient. These are all important tests that you can use in answering your questions and also use when you take care of patients in real life. I continue to say real life. I know the oral boards are actually real life, but they're case presentations at the same time too. This is not to minimize real life or the oral boards either. Parenchymal function, arterial blood gases. If your arterial oxygen is less than 60, you're at increased risk. And if your PaCO2 is greater than 45, I know I said 50 before, but if it's greater than 45, you are at increased risk. VQ scans, split lung function studies, used when other studies are borderline. They're not necessarily always commonly used. Split lung function studies are used for lung transplantation. Polycythemia, this would indicate chronic hypoxia. You have erythrocytosis, the patient can't get enough oxygen to the tissues. Subsequently, there's more hemoglobin, the hematocrit rate increases, you have erythrocytosis. Additionally, an indicator of polycythemia, or perhaps more of an indicator of hypoxia or hypoxemia, would be pulmonary hypertension or right heart failure. Pain management should be discussed with the patient. The best is an epidural, although you can get hypotension with an epidural. Hypotension with the use of local anesthetics. Generally, bupivacaine and Dilaudid are used, or rather hydromorphone. But again, hypotension can be used, especially if you're doing an extrapleural pneumonectomy when there's a sympathectomy, because they rip out the sympathetic trunk on whatever side you're on. You administer an epidural dose of bupivacaine, high concentration after they take out the sympathetic trunk. You're going to run into significant hypotension in that case. Intrathecal morphine can last for 24 hours, around 200 micrograms. And paravertebrals are used as well for these cases. Sometimes the advantage with paravertebrals would indicate a lesser incidence of hypotension and a lesser incidence of epidural hematoma. For induction, certainly laryngoscopy is appropriate. Obviously, go through the entire exam, difficult airway, what's going on, and position the double lumen tube with a bronchoscope. Guide it down with a bronchoscope. And for these cases, all lung cases, limit the fluid administered during the case, because it's very important, especially for patients who are having pneumonectomies. If you overload them with fluid, they may end up, unfortunately, going into pulmonary edema. And if they go into pulmonary edema with one lung, that's going to be a significant issue for them in the postoperative period, and they may require significant ventilation afterwards. It's always appropriate to extubate these patients. Now, what if we're doing single lung ventilation and we have let me go back. It's not always necessary to extubate these patients immediately after operation. It's very much preferred to extubate these patients because we do not want any positive pressure on the stump of the bronchus. Now, what if we have hypoxia with single lung ventilation? What do we do? So the saturation continues to decrease even though we're having single lung ventilation. Well, first thing to do, recruit the dependent lung. That's on the ventilated side, okay? Check the circuit, make sure it's not kinked. After confirming appropriate placement of the double lumen tube with the bronchoscope and making sure that the circuit is intact all the way through, I would recruit the dependent lung for 30 seconds with a PEEP, rather with a pressure of somewhere around 25 to 30. If that doesn't work, perhaps, and it's not specifically serious, so maybe your saturation is around 92 or 90 or even 88, convert to a totally intravenous anesthetic. This will have a decreased effect on hypoxic pulmonary vasoconstriction, something that the volatile agents inhibit. You may have to convert to 100% oxygenation. In my estimation, it should be assumed that patients who have a tumor generally are not ventilated with 100%, especially for cancer patients, because this may result in supraradical formation. And so at least where I did my training, we would try to maintain a FiO2 of below 30%. However, some institutions use 100%. So if you're not already at 100%, you might have to convert to 100%. If it still doesn't do anything, you could possibly do positive end expiratory pressure to the dependent lung. However, be careful in patients who have chronic obstructive pulmonary disease, because continuous PEEP, they already have a certain amount of PEEP intrinsic to them because they have chronic obstructive pulmonary disease. Their issue is with expiration. So their airways, they already have a condition called auto-PEEP. And in fact, auto-PEEP can significantly disturb venous return, and then you may at one point run into pulseless electrical arrest. You can then use continuous positive airway pressure to the non-dependent lung. You can even use passive flow with a catheter hooked up to an oxygen tubing. This may be better. Increase it to 2 liters. We don't want the surgical lung to be ventilated or the non-dependent lung to be ventilated. You can also use an ambu bag to ventilate the non-dependent lung, and you can look at the screen if they're doing a thoracoscopy, or you can also look in the chest to see if you're staying out of their field. And you may have to return to double lung ventilation, and the most serious is you may have to clamp the pulmonary artery. I would advocate using an ambu bag using one of the on the non-dependent lung, give small puffs of breath, because clearly there's perfusion to that side. There's a shunt. So give small puffs of breath to that side, because the most important thing is also to get the patient off the table to return best as possible to double lung ventilation. You can imagine how long a procedure would take if you had to continue to return to double lung ventilation for 2 minutes to make sure the pulse ox, or rather the oxygen, came up. Monitoring: place an arterial line in the dependent radial artery so that you can see if there's axillary artery compression, and place a central line in the internal jugular on the surgical side, so that in case there is a entry into the pleura and a pneumothorax is the result, then the case would not have to be especially canceled, because there will all be a chest tube going in on that side. Postoperative: generally require an intensive care unit stay for a pneumonectomy. A wedge and a lobectomy, maybe not, it depends on the patient. They should at least require a monitored floor. Now, before we go on, I'd like to just briefly go over the risks of double lumen tube placement. You could rip a hole in the trachea. You could make a hole in the bronchus. If you intubate the esophagus, you could perforate the esophagus as well. Especially if people are not experienced with double lumen tubes, you may not know how to use them. They may not know how to use them, rather. And as a result, they may attempt to ventilate the inappropriate side. They think that there's something wrong with the ventilator, and meanwhile the patient becomes hypoxic because they're ventilating the side, maybe in the intensive care unit, that is clamped. So be careful. Obviously, all of us should always be vigilant and careful every second through these operations and through their patient stay in the hospital. Some special cases: if a patient comes in with massive hemoptysis, and a laser might have to be used. A wake fiber optic sometimes is not the best choice because the field is blurred in these cases. A Fogarty catheter may have to be placed. A bronchial blocker may also have to be placed. The patient might require an awake tracheostomy. These patients may require a rapid sequence induction. Use suction, remove the heme from the airway, and then place the endotracheal tube. They may even have to go into the lateral position. Some patients may have to go to interventional radiology for perhaps a coil embolization of some sort of rupture. Pulmonary cysts and bullae, pneumothorax is definitely consideration in these patients. These are the special considerations, especially if one of them under positive pressure ventilation happens to rupture, then that can cause a serious issue. Do not use nitrous oxide in these cases. Nitrous will go into open spaces and may create a further pneumothorax, may make it worse. Spontaneous ventilation would be preferred because positive pressure has the chance to rupture the cysts and bullae. And in fact, a prophylactic chest tube may be appropriate for the operative side. And a prophylactic chest tube, by the way, is also appropriate if a patient has pleural effusion and you're unable to ventilate appropriately. For a lung abscess and bronchopleural fistula, generally treated with a double lumen tube. Try to isolate the lungs. If you're using a single lumen tube, low pressure ventilation would be the most appropriate for these patients. A lung abscess, the lung should be isolated and until treatment occurs or surgical resection. And these patients can also get very sick and possibly have sepsis. For a tracheal resection, again, recall those flow diagrams depending on where the mass is. Most likely, it has to be an awake fiber optic intubation, or at least maintain spontaneous ventilation and do the combined technique that we discussed before. Special things for this case would be including cross-table ventilation, so after the tracheostomy is placed, or rather after a an incision is made into the trachea, an endotracheal tube can be placed there, and then you'll have to do cross-table ventilation, so they should have a sterile circuit for those cases. And prepare for ECMO. It is not a bad idea to peripherally cannulate the femoral vein and also the femoral artery in these cases, so that in case a patient, there's a mistake or some issue happens with the aorta, you can quickly go on cardiopulmonary bypass. And finally, for lung transplantation, the anesthetic implications for these patients include pulmonary hypertension, so you might have to do awake lines. Some patients have suprasystemic pulmonary hypertension. Even patients who come in for a non-thoracic case, like an appendectomy. In fact, just to give you an anecdote, I took care of a patient who was 140/90 with their pulmonary arterial pressure, and their systemic pressure was 90/60. I'm not lying to you. This is documented. And in this case, The patient was able to make it to 27 years because of good reserve with regard to their right ventricle. They did have right ventricular hypertrophy, and the right ventricle was really going very, very strong. But that pulmonary hypertension was really, really significant. It all resulted from a patent ductus arteriosus that was not recognized. So in these patients, you may not want to do awake lines. You may want to do awake lines, but if they're causing significant distress to the patient, causing hypoxia and hypercarbia, awake lines may not be appropriate. Hypercarbia is not appropriate. Vasopressin is to be used in these cases, generally preferred over norepinephrine because it does not have a vasoconstriction effect on the pulmonary vasculature. Epinephrine is also appropriate, as so is milrinone, although be careful with milrinone because while it's renally excreted, it also stays around for a very long time and additionally can cause vasodilation. Epinephrine is good because it promotes inotropy in these patients. These patients may have right ventricular dysfunction and left ventricular dysfunction. And also, remember, ECMO can be used as a bridge for these lung transplantation patients that come into the operating room. And if the patient cannot be done off mechanical support, then the lung transplant can be done on ECMO or on cardiopulmonary bypass, depending on how the right heart is functioning and how the blood pressure is doing. Obviously, the same tenets for this and all lung surgery: do not give excessive fluids. You may have to give significant blood, you may have to give significant fresh frozen plasma or platelets or cryoprecipitate. At the same time, try to stay away from crystalloids and colloids as much as possible, only using that which is necessary to keep cardiac output high. An transesophageal echocardiogram is appropriate. Be careful on reperfusion. Reperfusion is associated with ischemic precursors that may come in. Rather, not ischemic precursors, but lactate and certain other neurohormonal characteristics that are present within the clamped circulation. These may present themselves, and reperfusion can be associated with a distinct drop in blood pressure, and the patient may in fact arrest. So be prepared with calcium and epinephrine as well, and make sure you have vasoconstrictors, as I discussed. And this is it. I'd like to thank Dr. Patel and Dr. Sakai and the rest of the University of Pittsburgh Department of Anesthesiology and the Division of Cardiovascular and Thoracic Anesthesiology here at the University of Pittsburgh. It's a pleasure to talk to you today. I hope that you were able to glean something from this lecture. I wish you all the best in your careers, whether it's your oral boards or taking care of patients. And I'd also like to thank all of the sources that I wrote from, which includes Miller Anesthesia, the website below, and also the Ultimate Board Prep, which is also listed below. Thank you so much, and all the best.